Welcome back to Broker Times. This is the best source of insights and ideas for insurance benefits brokers. I am your host, Ryan Ross, and as always with me, I got my co-host from Georgia's Dirt Trails with Grit in His Walk. He is the GA who responds quick. That is Stephen Combs of Broker's Block. Hello, Stephen. But wait, there's more. We got a cards fan and a deal hunter. He's sharp as a gun. We have the same haircut. Of course, I'm talking about our favorite broker, John Coleman. But wait, there's more. We have the PBM insider. He has knowledge in stock. He is fired up from Kansas City. That is Jim Lodge from Prescription Network. But wait, there's more. We got a tech-first sushi-fueled guy. He is innovating, but he's not in stealth. He's paving the way for tomorrow, and that is Caleb at Angle Health. But wait, there's more. Of course, we have from the boardroom to Shark Tank. His wins never shun. Changing the game, that is the legend of Mark Cuban. So thank you guys for coming on. Wonderful.
What's up, guys?
So what I want to do is we got a lot of ground to cover. PBMs, lack of transparency and opacity. We're talking about some inflated costs and misaligned incentives and rebates and kickbacks. So I want to refresh your mind on something, Mark, really quickly. You spoke with the Wharton School of Healthcare Management, and you were talking about the industry and how it's been disrupted. You want to disrupt it because people keep getting bought out, right? And you spoke at this conference, and you said, I quote, right? I don't need any more money. I'm rich as hell, so I don't need to do this for money. My joy comes from screwing the PBMs. Each one of these
screwing. You got to be literal. I did not say the word screwing.
Oh, well, I'm paraphrasing from the article, right?
So started with an F, yeah.
Yeah, oh, there you go. My joy comes from fucking the PBMs, right? So every one of these sales that we close directly from the drug manufacturers is a great day and the sun is shining brightly for me. So the question is, when did you realize that that type of joy was possible? How did you get into this industry at all?
I mean, I was working with healthcare, different elements of healthcare, probably starting in 2017 when all the discussion of overturning the ACA was happening. And I just had various people being here in Dallas saying, well, you know, you're an entrepreneur. Can you come up with something? So I just started understanding and learning it. And then a couple years later, I got a cold email from a Dr. Alice Oshmayansky, who wanted to start a compounding pharmacy to make drugs, injectables that were in short supply. Because as you guys know, it's insane, but Pitocin and pediatric cancer drugs, you know, sterile water, all go on shortage lists. And that made no sense to me. And it also was the exact same time the pharma bro was going to jail for jacking up the price of Daraprim. And I was saying to Alex, I'm like, if this dude can buy a 1 year supply, and I knew he bought the whole year supply because I said, why don't we just go ahead and try to buy it? But it was already bought by the one manufacturer. And I'm like, if this dude can do this, then there's obviously something really wrong. And as I dug in more, it was obvious that it was a complete lack of transparency. And it wasn't like this was a business where everybody loved the industry. Oh, they're doing great. They're just a little behind. Everybody loves working. It's the exact opposite. You know, we all heard the stories of, you know, people waiting in line at a pharmacy who, you know, turn around or embarrassed or dejected because they can't afford their medications, et cetera, et cetera. And as I looked at it, it was really apparent to me that the healthcare industry is one of the easiest businesses in all of business. You know, if you really think about it, you go to the doctor, hopefully the doctor says there's nothing wrong and you just go home. If there is something wrong, you know, you get a prescription or you get a follow-up. And for that prescription or follow-up, there's really only two questions. How much does it cost and how do you pay for it? But when you look at the industry, whether it's healthcare or medical, those questions are completely unanswered. And when you try to find the answers, particularly on pharmacy, you couldn't find them. So we started costplusdrugs.com with the whole premise that you go to the website and we would show you our cost. And then we would show you our markup, and it's 15%. How do we get 15%? Just grabbed it and thought it was fair. And then because we're mail order for that part of our business, it's $5 for a pharmacist to review and $5 to ship it to you. And the goal was to not only make it so people would knew what they were paying before they got their prescription, but also to get them to a point where they had a source they could trust. I'm a big believer that, you could, and I heard this on a podcast, you can turn trust into an equation. Trust equals transparency divided by self-interest. The more transparent you are, that's a bigger numerator. The less self-interest you have, that's a lower denominator. And a 15% markup was pretty straightforward. It was obvious to everybody we weren't trying to cheat anybody or rip anybody off. And as I said to all of our employees as we were getting started, and to this day, our product really isn't medications. Our product is trust, because that's what's missing in this industry. And so we published our prices. Probably the smartest thing we did was publish a price list. We launched on January 19th of 2022, published our price list. You could go to the site, obviously, and look up anything, but also published the price list to anybody who wanted it, all in a spreadsheet. And shockingly, it was probably the smartest thing we did, but even more shockingly, to this day, 3.5 years later, nobody else has published a price list. And that tells you all you need to know why we've been doing so well and why the pharmacy side of the industry is such a mess.
So before we get into like what a PBM is at all, and I'll ask Jim about that. Your book, How to Win the Sport of Business. In that book, you talk about this ad in PC Week, right? That had the cost of a PC peripheral going down every week. Yep. Whatever it was, right? It just kept getting cheaper,
every
right?
week.
It turned out that was a Michael Dell thing, right? That was his ad,
yep.
right?
That's why he's killing it. Yep.
Yeah, he's doing pretty well. So recently you spoke at this Wired conference and you said, and we have literally lowered the price of a medication every single weekday for the past almost 18 months. And that was a few months ago. And I'm curious, like, did that PC Week ad inform or like inspire that?
No, you're the first person to connect that, right? To me, it was just about, and I think it's smart for people who didn't know, back in the 80s, I was 24. Michael Dell, I think, was 21 working out of his dorm room. And the IBM way back then was if your costs went down, that meant more margin for you. So you just keep the margin. But Michael Dell said, no, I mean, the price performance of digital products were going to always go down as volumes went up and technology improved. So he passed on lower prices. And what ended up happening, he became the benchmark for PC peripherals and PCs themselves for an entire industry. And I didn't connect the two, but I probably learned from them that, we were doing the same thing. If you look at the FTC reports when they came out, they used our prices. When you look at all the ERISA lawsuits, they use our prices. We're the only price list out there, and we have become the benchmarks, which is why the big PBMs hate us so much, because any self-employed and self-insured employer or any federal or state agency can just go look at our prices and see what we've done, particularly to specialty generics. We've just destroyed the pricing for specialty generics.
Just because it's there to be seen. Amazing. So, Jim, you're our PBM insider, right? You guys have connected on LinkedIn.
And by the way, Jim, I love your videos. You stand there with that same sit there with that same microphone, just deadpan it. That's why I always repost them.
Well, I appreciate that. Thank you.
Jim, explain to us. You're the PBM guy in the room, right? Explain what a PBM is.
Well, a PBM's basic job is to administer the prescription drug benefits and support the plan and obviously the patients, but do it at the lowest net cost. I mean, it's no more complicated than that. Unfortunately, there are a number of bad actors in our industry, and as Mark indicated, they tend to be the big guys that are, essentially putting profit over the needs of the patient. And there is an actual need or a role for the PBMs, but it has to be done right. And some of the things that we'll do that I think are appropriate is, maybe step therapy. I mean, you got someone who is recently diagnosed with type 2 diabetes. Well, you don't immediately put them on $1,000 a month Ozempic. Let's try $4 a month metformin first. and that kind of thing. So there's definitely a role, but it's got to be done right. And unfortunately, a lot of people or a lot of organizations in my industry are just not doing it correctly because they see lots of money to grab.
Yeah, unfortunately, they went from, just as Jim mentioned, being a service provider that got paid for the service to aggregating hundreds of millions of lives in their formularies and using those formularies as an auction to auction off access to the formularies. And that's the nut of the problem in the entire PBM industry. If you disaggregate PBMs so that they only offer services, and in particular, disaggregate or divorce formularies from the PBMs, putting together a formulary is not hard, right? Having somebody manage it is not hard. It's easy. And that is where all of the PBM's power in negotiations are, particularly with brands. And we see it all the time where we go and talk to brands and we're like, why don't you sell through us? We'll sell it cheaper to your cash patients. Whatever the copay is for insurance, that's what it is. But you would save cash pay patients, in aggregate, tens of billions of dollars. And the response always is, we're afraid that the PBMs will diminish us on their formularies or remove some of our less competitive drugs from their formularies altogether and cost us hundreds of millions, if not billions of dollars. And they're, as much as they want to save patients' monies, they're beholden to the PBMs specifically because of those formularies. If they passed a law to disaggregate formularies, it's over. The price of medications in this country drop 30, 40, 50%. The executive order that Trump signed to match the prices for the OECD countries, literally, those other countries don't have PBMs. They don't use PBMs. And if you take out not only the rebates, but also all the fees that are charged, the amount of money that's charged for the manufacturers to get access to claims, the amount of money they charge pharmacies to fill brand claims. They're just extracting rent everywhere they can. If you just got rid of all that because you took away the formularies, our pricing would be damn close for brands because we're already cheaper because you get to compare the cost plus price list on those 91% of medications that are prescribed as generics. So we already know what's going to end up happening, and that's why the big PBMs fight it so hard.
I have a question that's not on our little scheduled list, but for these formularies or for the drug companies, can they sell to both guys like you and to the PBMs, or is it like?
Oh, could they? Yes, absolutely they could. There's nothing stopping them except the threat from the PBM, the big PBMs.
Yeah.
Because think about what happens, and I'll just use Eliquis as an example. The retail price of Eliquis is about $600, right? And let's just say the rebate, and this is probably approximately true, is about 60%. And so that means that the drug itself, if you just walked into a grocery store and needed to buy it and you didn't have insurance, or you have a high deductible, and let's just say you're young, you have an ACA plan and your deductible aggregate out of pocket is $95.10 or whatever the total is, right? So you're paying $600 a month right off the bat. With that 60% rebate backed out, so now you're at $240. We mark it up 15%, so we could sell it at $276. $276 for all those tens of thousands of cash pay, high deductible patients is a lot of money. You apply that to every single brand medication for anybody with no insurance, underinsured, high deductible plan, and you're changing how they are able to afford their medications and minimize, if not potentially eliminate, the number of people who have to go without or ration. Now, the reason the PBMs hate that is because if it's $600, even if it's if you're on an employer plan and that employer is getting rebates for Eliquis, which they probably are, even if it's less than it used to be, well, if they're not getting $600 whack at the pharmacy, right? That's that's rebate money that they're not going to get back from the manufacturer, BMS in this particular case, right? And so they want, they want more people going. They want those rebates to be high because that rebate money goes right to the PBM. But it gets worse than that. What people don't understand is, the PBMs try to tell, the big PBMs try to tell employers, self-insured employers, don't worry about it. It's the manufacturer that pays the rebate. That's not true. It's your sickest employees and your employees with the most chronic illnesses that pay for the rebates because they need utilization. If nobody's sick, then there are no rebates. And so you need more people going and paying as much as possible for those brand medications in order for those rebates to happen. And as a result, on top of that, you're getting for the most popular brand drugs, there's less pre-authorization denials because they want more utilization because the more people that use whatever the brand drug is, the more rebates paid to the PBM. And they're doing it wrong when they create these subsidiaries, two of which are based outside the country to negotiate rebates so that they're able to say to employers, we passed on all of our rebates, not telling them that this rebate GPO, this subsidiary company is keeping 5% or 10% of the rebates and then just rolling it up to the big PBM. It is a scam.
And not to mention not paying taxes in the United States on those.
Oh, yeah. And that makes it even worse, right?
Yeah.
And there's just so many ways that they do this and that just makes it worse. And so look at biosimilars. They're starting to come out. We have a biosimilar for Humira. It's $594. I think I just saw something. The price may be going down here shortly because our volumes have gone up so much, right? And so they won't add, the big PBMs won't add Usimri, the biosim for Humira, to their formularies. What they're doing instead is they're creating private label versions of the biosimilars. So they're going to independent manufacturers and saying, okay, you've got this biosimilar approved, manufacture it for me, the big PBM, and I'm going to create two versions of the same exact private label drug. And what I'm going to do is I'm going to have a high rebate version so that I can charge $1,100, which was still cheaper than the $8,800 that Humira was, but I can charge $1,100 and keep that big margin, right? Their version of a rebate. Or I can have a $400 version or let's just say a $700 version more likely, and just keep the margins between the two. And on top of that, since people are going to pharmacies to pick them up, other than their captive pharmacies that they own, they're charging the formularies a stocking fee or a sales fee in order for them to be able to carry it. And they're not even paying them like they do on brands, the full amount of the pharmacy's cost. And so these big PBMs are just gerrymandering their formulary, right, to benefit themselves financially. And I'll give you one other piece of information there. The biggest healthcare company, right, has 2,500 plus subsidiaries that are on that they have to roll up into their financials. The intercompany transfers for that big carrier are 151. It's 151 or 161 billion dollars a year. That is 0.3% of the entire GDP of our country. And when you look at these numbers, yeah, their numbers are down, their stock got crushed, whatever. They're still making billions and billions and billions of dollars, and they're able to game those numbers so that if, as best I can tell, if they want to have a certain number they hit for the medical loss ratio or certain things that don't count towards their medical loss ratio under the ACA, they can game that number, right? If they want to make it look, they do it by book of business, right? What happens under Medicaid, if they have Medicaid plans, what happens under Medicare, Part A, Part B Advantage, et cetera, what happens under ACA. They manipulate within each book of business so that they can present the numbers that they need to present for government, for IRS, whatever it may be. It is wrong. And that is why our healthcare system is so fucked up. And I can even go in deeper on the healthcare side on why, but you guys know it better than I do on what a mess it is.
Steven, you want to take the next one?
Yeah, well, so my question was going to be about how, many critics call PBMs needless middlemen, and what do you see as, the most unnecessary or counterproductive roles PBMs play? But I think you answered a lot of that just now. But if you have anything else you want to add as far as where you truly believe the misalignment's at, I would love to hear more of your thoughts.
Yeah, I mean, there is no alignment whatsoever, right? Look at this. When a PBM signs a contract with a self-insured employer, it's like Fight Club. The number one rule of Fight Club is you don't talk about Fight Club. Mm-hmm. The number one rule of the contract you have with the PBM is you can't talk about the contract you have with the PBM, diminishing transparency even more. But it gets worse. Or in the immortal words of Ryan Ross, wait, there's more, right? When it comes to self-insured employers, they are not allowed to talk to manufacturers. So you want to do a wellness program for GLP-1s. It makes perfect sense, depending on how big you are, that you'd want to go to Novo, you'd want to go to Lilly, whoever, and say, look, I want to put together a wellness program. Should I use metformin? Should I use Brenzavvy? Should I use Wegovy? Should I use Zepbound? I want to figure all these things out. They're not allowed to do it. That is insane. Unless you're so big, qualifier, so big you can get a carve out, because you had one PBM who literally sold the rights to GLPs on their formulary and precluded the other player in that business. But again, in the immortal words of Ryan Ross, wait, there's more, right? Because not only can the employers not talk to the manufacturers don't even get all the claims data. And so if Lilly or Zepbound wants to look at adherence rates, wants to see, what percentage of their patients stay on and for how long, they don't get that data. They have to buy it. And they have to pay as a percentage of WAC, which is insane. I think, Jim, was it you that said, you have a problem if anything you're doing in your contract is priced at a percentage of the drug price?
That's correct.
Sure yep.
Yeah, basically.
Then you're getting ripped off, right?
Yeah. That's the magic question. Yeah.
Perfect segue. What is that magic question? What's the magic question, Jim? You had a YouTube video about this, right? Like, what's the magic? Yeah. It's the simplest thing. What's the magic question that should be asked?
Here it is. Do you, Mr. or Mrs. PBM, take any revenue whatsoever tied to drug price? And that's it. And if the answer is yes, then absolutely, Mark, you're getting hosed, because they're perversely or conversely incented to drive the price up as high as they can. And that can be at any level. I mean, to your point earlier, they own these GPOs. I mean, the same entity owns these GPOs as the big PBMs. Well, those GPOs are taking, marketing fees and formulary management fees and all those fees. And the GPO fees are a percentage of the rebate. So they'll say, well, we're paying out all the rebates. It's like, yeah, but you're also getting this, you got the side hustle going with these fees. Yeah.
You know what the worst of all these side hustles are now? I just heard this from a big whale employer. They were told that one of the big PBMs is now getting exclusives on cell and gene therapies. Think about how bad that is. Yeah. Meaning their cell and gene therapies are the drugs that cost millions of dollars that can fix hemophilia, that can fix taste. I forget the other diseases. That with just one implementation, injection, whatever it may be, right? Done. But they did deals with these guys so that nobody else could make them available. Think about that. If and I don't know the specific drugs, but let's just say one of those drugs cures hemophilia, and your insurance is with somebody, or your employer doesn't even have, is willing to pay for it, but doesn't even have access to it because they have an exclusive. That is criminal. That literally is because of exclusivity. Somebody could die or just be put in a position where, what could be cured can't be cured. That's brutal. But that's, that's what is happening in the business. You guys, the brokers here, you guys know what it's like when you try to get claims data.
Mm-hmm.
What happens?
It's crazy.
It's ridiculously difficult. Like we get very limited claims data from the carriers, and even less on the prescription side. It's definitely a challenge to consult your clients when you're given limited data.
It was crazy. Just like a month ago, I went to get claims data from one of the players, and we asked for it in Excel format, claim level data. We got to have prescription by prescription to do the analysis. And they sent me it in PDF. And I said, no, I need it in Excel. And so they took the PDF, pasted it in an Excel file on different, and then sent it to me. I'm like, well, that's not going to help me, bro.
Well, the good news now is when you get those, you can use AI to convert it, right?
That's true.
Right.
Just put it in,
Right.
you can put it in one of
This wasn't
ChatGPT or
an
whatever.
AI conversation, but it'll inevitably it goes to that, right? It's a great solution, but my gosh, it shouldn't have to be that way.
I will
No,
add real
exactly.
quick to that topic about using AI. Just be really careful when it comes to using claims data because you can actually violate HIPAA.
Right.
So you got to be real careful with that. Just making sure that you're not. Just
Yeah, you
plugging
have
in
to protect
ChatGPT.
against sharing. I mean, you've got to wall off what you're doing. But look, I mean, claims data. Why do they not want you to have claims data? Because they know they're ripping you off.
That's right.
It's the same with audits. Try to do an audit. They're not going to let you do it, or they'll give you, do a statistical audit. You have 100,000 claims this year. Here's 47 of them. Just ridiculous shit like that. Yet, we still do business with them. You guys are the brokers. Why can we not convince these employers to do the right thing for their members?
That's a great segue, right? Initially, I was going to go to lack of transparency and opacity, but I think this is a really good way to bring John in and talk about some renewal issues that he was having to deal with, but then also talk about like educating clients on these things, right?
Yeah.
John, can you tell your story about that renewal issue that you were running into?
Yeah.
There was just not a lot of transparency there.
Sure. One of my clients of 35 years, about 8 years ago, their renewal came up and they got a 27% increase from one of the largest insurance companies in the country. And I looked at the loss claim ratio and it was 81%. And if the loss claim ratio is 80% or less, the group really shouldn't get an increase or very, very minimal, right? So I immediately called up the renewal rep and I'm like, hey, Susan, what's going on here? And she's like, well, they have really high prescription drug utilization. I'm like, really? I go, well, we all know you're keeping the rebates. You're not giving them any credit for it on the renewal. So if you actually gave them credit for the real rebates, we all know that the real loss claim ratio would be below 80%. I said, this group shouldn't even get an increase. I go, I expect it to go away, the increase. Within 5 minutes, I had a phone call back. It dropped from 27% to 5%. And I said, hey, that's not enough. The whole thing needs to go away. And she said the underwriter won't go any lower. I said, that's fine. Shop the group out like we always do anyway. And we were able to get rates 10% cheaper than the rates we had the year before. So I think all this comes back to the transparency thing, Mark, and everything you're talking about. So what it really boils down to, I think where a lot of people are being failed are actually the people in my role, where they actually are supposed to do the work and go to companies like Caleb has at Angle Health that actually provide real solutions, and really like Steven's company is a GA. They're actually providing TPAs, third-party administrators, that pair up with PBMs that actually do the right programs to get all those rebates either eliminated or put back into the client's claims bucket. And the big insurance carriers aren't going to do it. They're controlling about 80% of the PBM market. And unfortunately, the bigger the group gets, then you start talking to the big consulting firms. And from what I've seen on the big consulting firms, their favorite line is, and this is even true in the small groups, but their favorite line is medical trends running at 9.2 right now. You're only getting a 10 or 12% increase.
That's what I used to hear with my companies all the time. It was insane.
It's just total bullshit, right? So, and so we say to every group, well, if it's not that big of an increase, well, why don't you tell them they ought to pay it, right? And we all know, obviously, that's not going to happen. But I mean, we have a group we picked up, put with Caleb's company. We shopped them out. They had 600 employees. What happens is the rates get so high and the insurance gets so expensive and the coverage drops that employees start dropping off. So when we picked them up, they had 216 employees on the insurance. That's it. You guys are going to fall out of your chair when you hear this, but we saved them $2.4 million. They weren't getting their rebates, got them the rebates, all that, but a bunch of other great things that Angle does. And then on top of that, then when we took it away from one of the largest consulting firms in the country, actually in the world, the head of the region called up to the CFO and he's like, hey, I just want to let you know you're going to get a 40% increase next year. You're going to be coming back to us. And she's like, I don't think so. So she called, she tells me all this. She's like, are we all right, John? I'm like, absolutely. So the renewal came around last year and they got no increase because the programs actually work, right? And now we're going up, getting ready for the third renewal, and they're probably not going to get another increase, which is just amazing on a group that big. And they're up to, I think, about 260, 70 employees now, just because the programs are better and it's affordable, And on top of that, because of the programs that they have at Angle, the members actually get a lot of their drugs for free that they were having to pay their out-of-pocket maximum on. But I mean, I see this every day, all day across the board. The big consulting firms, what they're doing, they're in bed with the big insurance companies.
Why Milliman, Brian something or other, said that PBMs aren't as bad as people are making them out to be, that they're really transparent with Milliman because we're open and honest with them, right?
Yeah.
We don't share our data. What nonsense.
Yeah, no, it's all BS. And actually, the smaller the group, the more they get screwed, right? And most of them don't know what's going on. Most small business to medium-sized business owners do not know even about the rebates. So we educate them on that. Most brokers that do what I do don't know about it. So we're like a boutique firm that competes against these big consulting firms. And when we can get back to, you were talking about, Jim and Mark, getting the data. If we can get the data, we beat them every time because they're not going to do the work that we do for our clients, right? So for all the other brokers that are out there that are looking to compete against them, put the work in, work with people, like we have here on the call, and you'll be able to produce great results for your clients that actually work.
Always add costplusdrugs.com to the network.
Yeah,
always.
Yeah. By the way, Mark, my wife has MS. Her doctor's Barry Singer in St. Louis. And he's been referring a lot of people to your program.
I appreciate that.
And so much so, some of your people caught wind of it and actually reached out to him. So you really do, on a lot of the MS meds, have great value there for all the members. It's really
that's definitely. Which brings up the next question: why is there a specialty tier at all?
Right.
Why, to Jim's magic question, right? It's the same thing applies when I talk to people. If you have specialty tiers for any generics or biosimilars, you are getting ripped off. If it's not a cell and gene therapy type thing where you've got to evaluate for step up or pre-authorizations or whatever, because it's a infusible type drug, there's no reason. And that's like the number one, the two things. There's the magic question on price versus the drug cost or fee cost versus the drug cost. And then there's specialty tier. There's no reason in God's green earth to have a specialty tier. All drugs are special in their own way.
I feel like the specialty tier is probably like and you probably wouldn't know this. I don't know how much you play commercial, Mark, but it's like the best, ultra gold standard on JetBlue or whatever it is, right? It's like, let's just charge a little bit more so that they can enter the plane early and get a glass of champagne. Maybe that's what it's like. I don't know.
But you don't even get the champagne, and you don't get to enter early. You get opposite, right? You get told you're in first class, and then they fucking make you face the wrong way at the last two rows in Southwest, And so
you're
it's just like
at the flight attendant straight on.
Right?
Instead of specialty, it's the massive rebate tier.
If y'all don't mind, I'd actually love to get Caleb's perspective on that question, being that, they build their plans pretty much from scratch. I'd love to get his perspective on Mark's great question.
Yeah. I mean, so as it pertains to specialty tier for us, right, is
Caleb, what's the
you
name
know
of your company again?
it's Angle Health. So we're
Okay,
a
I've
full
heard of it.
stack health plan, right? TPA, MGU carrier, et cetera. And we're really focused right on complete alignment and transparency with the group, and actually again delivering our own product and not marketing other solutions and kind of delivering Frankenstein health plans to the market. So all that said, right, why we have a specialty tier. Um, is simple, quite frankly, in that to some extent, employee benefits are something that employees have a certain expectation of how they're going to perform. And so with that, they have a certain expectation of how a drug plan is going to work. They want to know that they're going to walk into their pharmacy and they're going to pay X dollars or Y dollars or what have you. And they want the ability to say, hey, if I'm on this drug, I'm going to have a prior authorization, right? They want that opportunity to understand that.
Why don't you
So,
just say it by drug for my employees, we created our own plan effectively, right? We
mhm.
do direct contracting. If you stick within, if it's anybody that we have a contract with, or if you're buying a medication from Cost Plus Drugs, there's no out of pocket whatsoever. Now for brands, we just say, here's what it's going to cost you for each individual brand. And I get your point about the expectation, because that's just the way it's been done.
Sure.
And you don't want to have to overspend too much time having to educate members who are making decisions very quickly. Get that. But when you tell them, instead of a co-insurance on imatinib or whatever it may be, because it's generic, you're going to have a flat copay all the time. I don't think they're going to be upset.
I would actually, I mean, being upset and ultimately giving something that, the Johns of the world are able to articulate to the masses, right? I think is kind of two very different pieces. I think the employee's ability to understand a four-tier system that they've been ingrained with for the past 10, 15, 20 years is very different than trying to give them the opportunity or the ability to go look up their drug, right? If we're building something for the average SMB client that John and many others serve, who the employer never got into the space to offer benefits or to be a health insurance company, but as a self-funded employer, right? Guess what? They're now a health insurance company. They now need to be able to deliver something that's familiar, and more than anything, they need to deliver something that works, right? They
When I
don't
see
want to
that
retrain.
as an entrepreneur, my mind's going ding, 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 ding. Next line of business coming up, right?
Hmm.
We'll extend, cost plus so that and this is what I do anyways. I talk to CEOs because to John's point and to your point that, CEOs don't know anything about healthcare plans. That's not their
Totally.
core competency. And everybody underneath them, particularly the bigger the company you get, they're afraid to go to the CFO or go beyond the head of benefits and talk to the CEO because that rebates all that CEO understands. And so I get all that, but that's why these pass-through PBMs are making progress. We're partners with like 30 of them now, and in aggregate, they have like 22 million lives. And so, they go in there and they say, you're out of pocket on this. There is no co-insurance on anything generic anymore, right? I don't think it's that hard to explain to them, but I get your point. As a guy who's been a salesperson his entire life, the path of least resistance typically is the easiest way to sell. But at the same time, when you're able to save companies and patients money, that talks loudly, I think. And our pass-through PBMs have not had challenges in educating people because it's almost like the whole thing of pick your copay for healthcare, right? For surgery or whatever you're getting, we'll let you use your HSA or ICRA or whatever it's called, right? To go find the cheapest copays and work that approach. Just I guess from my perspective, when I see a specialty tier at all, it's a huge red flag, even though 99% of plans have specialty tiers.
Yeah, they mostly do. I will say this, and I think you'll like hearing this. Well, maybe. So I actually signed up for Cost Plus on Friday,
I
and
like hearing
so
that all the time.
yeah, I just figured I was like, oh, I've heard of it a million times. I've used GoodRx in the past. This seems a lot more intuitive than GoodRx, and so I signed up for it, and I use Angle Health for my health insurance.
Oh, just when you're talking about cost plus, right?
Yeah,
He
we lose
costs
Steven.
out.
Hold on. I'll get him back. Oh, where'd he go? Let's see. Backstage show. Steven, you got to go back.
We lost
Jump
you.
down.
You lost me? Or can you guys hear me now?
You signed up for cost plus.
Yeah, and I plugged in my Angle Health pharmacy information, like the BCN number, all of the BIN number, and y'all actually integrate with their PBM, which I found really cool. I didn't realize that you guys did that. So now, whenever I go get a medication, I don't go to the doctor very often, but I do every now and again. And next time I get a prescription, I can compare it against my PBM and versus
No,
cost
and
plus.
Angle's been great. That's why I asked which PBM, because we're just there to save money. With cost plus, we don't say to Angle, you got to use us for everything.
Mm-hmm.
We just say where we're the cheapest, use us. Where we're not the cheapest, don't use us. Because I know, anything specialty generic, we're going to be cheaper.
I
think
think the
that's
option's really nice. And sorry,
Yes, I
go ahead,
think
Caleb.
I think that's too right. Where I mean, in the SMB space, when you've got a carrier that owns a PBM, right, and there's that complete misaligned incentive. I mean, Stephen, John, you both can both speak to it, right? What we seek to deliver is let people access the care they want to access wherever they want to access it, right? So, look, if you want to overpay for a drug,
More power
so
to
be
you.
it,
Yeah.
right? Like, so be it. If you want to go buy, that more expensive drug at a, slightly more convenient location, like, okay, understand what that means, right? And understand what that
Understood. Yeah.
means
And I
for
agree
you as
with
a
that too.
self-funded employer.
You can't force people to act in their own self-interest.
So, Caleb, when you guys are working with PBMs, what do you look for in a PBM partner? What are the qualifications or requirements that you guys look for?
Yeah, I mean, so we look for, I mean, ultimately, more than anything, we look for our broker partners to drive what's best for their clients, right? We view ourselves as a manufacturer of a health plan, a chassis to build a health plan upon. We're here to deliver solutions, right? We've built solutions, we deliver pharmacy options. At the end of the day, right, we are not the consultant, right? We are the manufacturer that delivers ultimately a wholesale or a retail product for individuals like Stephen and John to represent to other brokers or to the end client. And so, while we can use economies of scale, while we can deliver what we feel are best in breed solutions, if a consultant has built something they feel is better, or has used something that ultimately, again, they trust. So much of employee benefits is a trust sale, right? Much more so than it is a better product sale again, you could create the best way to go access healthcare. If it's complicated, if it's brand new, at the end of the day, you have cancer, what you want is you want to go to where you feel like it's best and you'll pay whatever it costs for it. And so what we've done more than anything, and again, we have an Angle RX product where we white labeled a bin and a PCN, and again are delivering something where we make zero revenue on the pharmacy. At the end of the day, we're a manufacturer of a health plan, right? We're a chassis to build something upon. And so whether that's using the solutions that we have kind of on the shelf or bringing in new solutions, what we can do differently here is allow our broker partners and our employer plan sponsors say, this is what I want. We'll rate for it. We'll price it accordingly. We'll integrate it and we'll ship it back to them.
Which is
That's
smart.
what we care much more about than saying, this is how you have to do pharmacy.
And are you guys using wraparound networks or are you direct contracting? What are you doing on the medical side?
So on the medical side, we lease PPOs. So we lease Cigna, Aetna, what have you. We allow broker partners again. At the end of the day, what we do really well is we know how to pay claims and we know how to take risk, right? And do so efficiently, right? With an AI native stack. But we're not in the network game, right? We don't know what's going to be best for the SMB client, in the St. Louis
So if
market
we
versus
have
the Kansas City
5,000
market.
providers, if we're coming up with a new line of business called Cost Plus Wellness.
Mhm.
And it's kind of eat our own dog food for my companies, my members. And what we've done is negotiate direct contracts with all these providers. And what we've said to them is, look, number one, just the whole design of plans today, if you think about it, when these big carriers design their plans, they're increasing the deductibles, it seems like every year, because they want the premiums lower for the programs they offer, so more people sign up. But what they never do is a credit check for any of the deductibles. And so the reality is, what's the average deductible you guys are seeing right now, Caleb?
North of $2,000.
Right. So $2,500, give or take, right?
Yep.
There ain't 50% of America that's got $2,500 in the bank.
Mhm.
Right. And so the carriers know that there's a really good chance that because of the deductible, the higher it is, particularly for young people who are taking the highest deductible plans, right? They're not going to use the health care at all. And if so, that's just saving them money, even when they're collecting premiums. That's one. Number two, if they do go to the hospital or to a provider and they don't have the $2,500, that provider is offering them financing through a third party or directly, right? So effectively, we've turned our providers and hospitals into subprime insurance companies. And when you talk to the CFOs of these hospitals or practices, whatever they may be, as they integrate, depending on where they are, they'll lose up to 50% on that. And so now all of a sudden they're down 50%. But in the immortal words of Mr. Ross, but wait, there's more, now they've lost all that money on the credit. But when it comes time for the carrier to pay their negotiated rate, they never pay the full negotiated rate. They always underpay and say, come and get it, right? Let us know if you want to sue us, whatever you want to do. So that's another 3 to 5% on top of the 50% of what they financed. But wait, there's more. Then you've got your pre-auths, and your pre-auths aren't even about denials, right? The pre-auths are about delaying. It's just a delay tactic to earn the time value of money on the premiums. And so now they're making money off of that, maybe some pre-auths that they actually do deny, plus the time value money, plus what they underpay, right? And then when you look at all of this, we just walk in and we say, okay, you're losing all that money and you're negotiating these prices with the big carriers, but any schmo with a credit card for almost anything can walk in and get a cash price. That's how much pain and cost they introduce to the providers, so that it can be 40%, 50% if it's just a basic service, 70, 80% if it's more. We want that cash price. That's what we said to them. And for all of our members, there's no pre-auth. We'll work with you until you give us a reason to kick you out. So if all of a sudden we're finding there are 5 back surgeries a week, you're gone, right? We can't trust you, because trust is everything in this side of the business. And we'll pay you cash up front, just like somebody walking in with, a stack of cash in their pocket. And in exchange, we want the best price. And they're giving it to us. And we're using it for my companies, and we're saving 9, 10% on medical claims because we're using cost plus. Obviously, we're saving a whole lot more, 30, 40% on the pharmacy side of things, even when we're, only getting minimal reductions. And then we use a wraparound network depending on where we are, and it costs like $18 per member per month. And then we go to reinsurance, and I think it's for $50,000. We pay, $275. Don't quote me, but right around there, $275 a month for our reinsurance. So now we're packaging all this up, and what we're going to do is take all these contracts we've negotiated, and we're going to put it on costpluswellness.com so that everybody and anybody, so all the brokers can come in and look and see, okay, well, the easy stuff, the hip replacements, the knee replacements, whatever, Mark, Cost Plus Wellness has got a better price. For the more complicated stuff, here's the contract that shows what the calculations are. If you're inpatient, if you're outpatient, if you're there for 7 days, the price goes, how they play all those games, right? I'm still learning a lot of that stuff. But the point being that we feel there's a unique opportunity. And so you guys as brokers and Caleb with Angle will be able to take these contracts, and they're not national yet, obviously. We're starting in Dallas and Texas. If you have any business there, but the prices are amazing and they're contractual, and you literally will finally have the ability to compare contracts to see what your stuff looks like to ours. And maybe yours is just a ton better, right? But where you don't, to your point, Caleb, of you Frankenstein it and put in the best option, you disaggregate everything, and you charge for the TPA, you charge for all this stuff. You'll be able to plug and play all of this stuff. And we're already seeing people come to us and offering us contracts just because of my employee base. And so I think there's a real chance that once we release all this stuff before the end of the year, you'll start to see people freak out in the healthcare side. And then wait, there's more. And I'm curious what you guys think about this part of it. We're working with our PBMs, and hopefully some of our folks, Caleb, have come to you to try to move stuff from J code and G code, I think it is, on the medical benefit side over to the pharmacy benefit side. Because the medical benefit side for certain drugs are just ridiculously inflated, and they'll charge $5, $10,
Oh yeah.
$11,000 for something they pay $1,000 for. And by putting that on the pharmacy side, we can reduce that cost for them as well.
And you can put it in their house, right? I mean, so that's where
Yeah,
it comes back to that experience, right? Do you want to drive, you live in rural, wherever, do you want to drive 2 hours to an infusion clinic and pay 5 times the cost? And we'll bring it right to you. We'll waive the cost entirely. Employer plan saves,
amen.
member saves. There's few
Yep.
things I think where you can oftentimes point to, everybody's mutually aligned, obviously outside of, the hospital in this case or whoever's billing that. But the
Mhm.
member's winning, the employer is winning, and candidly, the plan's winning, right? Again, so long as your incentives are aligned. We often say,
Yep.
we'll bill a client $100. We hope they spend 90. We just made 10, right? It's the most aligned we could possibly be in the employer plan sponsored space. But, to your point on these high performance or these direct contract solutions, I mean, we rolled it out with a few different partners in Michigan and Florida and some other markets. And again, we waived the member cost share entirely, right? We're looking at 10 to 15 points better on the discounts. We're losing some of that back on the inducement factor, right? Another 5 to 10 there. But if we can print, a max fully insured premium equivalent at 3 to 5 points below, and we can stabilize over a 5-year cost curve, we haven't quite solved healthcare, but it's a damn good start, right?
Exactly. Well, I'll connect you with Ryan, who's negotiating all these things. But tell me what the inducement factor is, because that's new to me.
Yeah, so right, the inducement factor is effectively the reason high deductible health plans, right, are quote unquote cheaper is that people are less likely to use it, right, because they have X amount of cost exposure. Well, the lower you bring that deductible, right, the quicker that quote unquote insurance, right, or employer plan sponsor pays, then members are more likely to use their benefits, right? So if we waive that member cost share entirely, right, we waive prior authorization, we waive all of that, members are more likely to use their benefits, right? There's more cost exposure to the insurance company. So while ultimately, again, if we're
But
saving 10, 15 points on
that's primarily
discounts,
the self-insured employer, though, right? Or
totally,
the self-insured.
100%. Yes,
Okay.
exactly, right? So you're losing that inducement factor because people are actually using their benefits versus, again, delaying. Now, there's the actuarial argument of, okay, if you get somebody to not prevent,
Right.
right, coverage, right, and they actually do seek care, are you preventing catastrophic claims? And I think that, remains to be seen on some of these higher performance contract solutions. But at the end of the day, again, if we're able to print 3 to 5 points and stabilize, more than anything, stabilize, right? I think that's the differentiator
So
in
when you say
today's
inducement,
market.
you're not paying a fee to a provider.
No,
No, no, no. It's
not at all.
just like we're doing, right? Where there's no copay, there's no
Correct.
co-insurance.
Members are
So
more likely to use their benefits. But
right.
again, we put a national PPO behind it. If you don't want to go to those contracts, you got your standard benefits behind it, right? You can go
Yeah,
pay more if you want to pay more.
for sure. For sure. And yeah, and for each company, they work with their members, and you're going to have a healthcare CEO in the middle anyways, trying to determine what's going on.
Totally.
Yeah, that's what we do as well. Now we need to see if we can work more on the healthcare side, because we're trying to push more. And if you've got some of those contracts, the only thing we ask is that we can publish them,
Yeah.
because the more it's published, the wider spread it'll be.
And we don't own our contracts. We allow our broker partners, we allow contracting entities to bring those to us. Because in the end of the day, again, we take risk, we pay claims, and that's what we do really, really well.
Right, right, right. That's your stack, right?
Jim, I want
Yeah,
to
well, even
redirect
connecting us
you.
with the brokers.
Yeah, for sure.
Jim, question for you, right? We're talking about the rebates and PBMs withholding their rebates. Why? How did that really emerge in the industry?
Well, back in the late 80s and into the 90s, the manufacturers started paying, these relatively modest kickbacks or bribes that they called rebates, but I guess they called them rebates to make it sound a little less repugnant. But the idea was, hey, we're going to we're going to put your drug on formulary versus your competitor's drug on formulary for the same condition, right? And so, but as we got into the 90s, 2000s, and beyond, those rebate amounts started growing and growing and growing. and the clients started to figure out the PBMs were just keeping them as an offset to some of their administrative costs. And you saw clients out there in the early and mid 90s that had a $0 admin fee because they were making enough money on the rebates that the PBMs were that it could offset it. But as the clients figured out, hey, that we paid that in the first place, the rebates really should be ours, and they started demanding that those come back to them, then all of a sudden PBMs were like, well, we've got to figure out a way to replace that revenue, so that the rebates got jacked up more. And then later you saw the GPOs come into play, and they started charging all these fees that weren't called rebates and whatnot. But I think that as they grew, the PBMs, it really caused the large PBMs to start being a lot more concerned about shareholder profit than they were about the patient. So you saw profit over patient start to emerge because these rebates became such a big deal. Now, one thing that a lot of people don't talk about is them holding those rebates like you're talking about for maybe 3-6 months. And I'm like, how the hell is that okay? These are not chartered banks. A PBM is not a chartered bank. So why in the hell are they making money off of somebody else's money? So the right thing to do is to immediately treat those as on a cash basis, and just get rid of them as soon as you can, maybe on a monthly basis, pay them out. And that's what some PBMs do, but not nearly enough. I mean, most of them are leveraging that to make money along the way. So
I see. Well, I think because this industry has kind of snuck in there, right? The PBM, the opacity has snuck in there, and now it just seems like that's the way it is. I think, Mark, with your just general spreading awareness that this is happening, that maybe that's making the consumer more aware, but they really aren't. Because, John, my understanding is also that you're not seeing people at companies saying, "Hey, we want to get some more clarity on our pharmacy benefits." They just don't even know the questions to ask. Is that right?
Yeah. So basically, what we see is most people don't even know about it. HR directors, CFOs. Do some know about it now? Sure. It's a handful of people that maybe ask about it, but most are in the dark. Matter of fact, I think most brokers, unfortunately, are in the dark. The firms that know about it are big consulting firms, but unfortunately, they're in bed with the big carriers, and they have an arrangement. The carriers aren't going to want to let go of the PBMs because most of them are publicly traded, and they need that revenue to feed the machine and meet their quarterly shareholder expectations. It's just a bad combination. So, but that's how we're able to come in and working with companies like Caleb and some of the other companies that Steven has, and literally slash the rates by a minimum 20-30% usually, and deliver a better end product. By that, what I mean is the member's going to get their meds, those specialty meds, at no cost, most likely, right? Instead of meeting their out-of-pocket max. But none of that is usually explained to the clients. I can't tell you how many groups of 2,000 to 5,000 I've come across that are with one of the big consulting firms, and they either don't shop them out, or they move them from one of the big ones to one of the others, and that's it. I mean, we go to the market and we hit everybody, right? And we just
No
shred.
one ever got in trouble for selling IBM, right?
Yeah. I mean, it's just sad. I mean, I literally know of a firm here in St. Louis. It's about 5,000 employees. They're with one of the big consulting firms. They're fully insured, 5,000 employees. And they told the guy that he's only paying $130,000 a year in commissions. Yet they have about 12 people on the account, right? Because they send over their marketing crap. All of those people, the cheapest person on there makes about 80 grand a year. So how are you pulling this off, right? So we all know, right? And Mark, I don't know if you've ever heard of it. I'm sure everybody else on here has, but have you ever heard of panel carriers? So on my side of the fence, that's kind of what we know about a lot of the big consulting firms. They go and basically work out backroom deals with the carriers. X number of
That I know that they do. Yeah, I didn't know that they were called panel carriers.
Yeah, we just call them panel carriers. So, and then they may even pick a TPA or two and do the same thing, but then they just put all the business with them. And if somebody like me comes along and they know what we're doing, they know that we actually work, they may do more work, right? But most of them don't take us serious because they don't know who we are. and we just clean their clock,
Well, that's when you guys start bringing me in, right? If
Yeah.
you've got a 5,000 employee deal and you're including cost plus drugs, you get me in something like this and I'm in,
Okay.
right?
All right. Absolutely.
You know,
Yeah.
my email is Mark, and you can even put it out there. My email is mark@costplusdrugs.com,
All right, Mark.
right?
Yeah. One of my
My goal,
clients,
same Caleb, right? If you're working on a customer too, right? We're partners already. I'm happy to come on a call and help you get the business. You know, because usually I spend most of my time trying to educate CEOs how rebates are a ripoff, right? They're paid for by your sickest employees. And as good as it sounds, it's going to sound a whole lot worse when a tragedy happens, like that kid in Wisconsin who couldn't get his inhaler, and you're on the front page of the paper because somebody couldn't afford the co-insurance because you set up a specialty generic tier or a specialty tier, et cetera, et cetera, et cetera, right? Also, you can get rebates or whatever it may be.
yeah.
Well, and the big consulting firms, to your point, John, they also have what they call, consortiums on the PBM side.
Right.
And I was talking to one consultant, and I said, hey, do you have a special deal with such and such, one of the big three? And he said, well, actually, no, we've got a consortium, and we pick the best price for we present it to the client and recommend the best net cost or whatever. And I said, well, who's in your consortium? And he said, well, it's the big three. I said, well, we know all three of them are ripping people off. So I said, you're okay with your client getting ripped off, I guess. And that didn't sit well.
On top of that, there's the consultants are setting it up so that there are fees just to respond to RFPs because they know that those, like I helped one state, and the governor, they had the governor on, they had the head of medical, head of benefits, and they said they were trying to get claims, and they had to work to get claims because I told them they needed to get copies of their claims to audit. And they said they finally got a chunk of their claims, but they made them sign a document saying that they would not show them to the governor of the state.
Oh,
I mean, it is just insane, and it's just stuff like that. That shit, that's the mission, right? We've only been in business 3 years. The whole anti-PBM has been around a while, but it's only really become vocal recently where you're seeing states move and all that. So people are becoming more and more aware that PBMs are the problem. And I'm not a Trump fan, but his executive order and bringing to the forefront, that prices should be lower is helping, and I think that's going to help people realize even more that they are getting ripped off, which is what makes this is why our business is up and to the right. And with biosimilar savings, the medical codes, all this stuff. I mean, there's just so many ways you can save all these people money. And by the way, the minute, the second we're able to get brands from the brand manufacturers at cost plus, it's over. What we did to specialty generics will happen also to brand medications, and there's nothing left in the rebate game.
What do you mean by this? As in like, so the top tier drugs, right? The ones that are advertising it. Is that what you say? Like figuring out how to?
Yeah. All the big brand name ones that, are 10% of the prescriptions and, whatever, 80% or whatever it is of the money. The reason why the game is over is look what happened to specialty generics. You take a drug, MS drugs or imatinib, right? Nobody knew what the real price was before we started publishing our price list. And so if you had a high deductible and you walked into a pharmacy, whatever they told you the price is, that's what the price was. You had no way to compare. And it was the same whether you worked for a big company, whether you had ACA, whatever it was, right? And then we started publishing our imatinib prices, and our imatinib and all of our specialty generic prices, as our volumes went up, our prices went down. Where Ryan mentioned, we had that streak where for 18 months, every weekday, we announced a price reduction. And so what ended up starting to happen was HR, CFOs, you name it, head of benefits at these companies started looking at the WAC price, which was all they knew. They didn't know about net after rebate, and comparing it to our specialty generic price. So there's no rebate on the generic side, sorry. But but they were comparing their imatinib price, which could have been $1,000, $1,500, to our $34.50 plus shipping and handling price. And they got mad. And they went back to the big PBMs and said, how can this guy who's been in business one day have a better price than what we're paying? So we changed it. So now all of a sudden, we still get emails. I get emails all the time. I walked into this pharmacy. My price for this medication was going to be $903. I looked on Cost Plus Drugs and it was $47 or whatever it was, right? That happens all the time still. But now imagine if we only have a 15% markup, and even if we don't get a net price that's equal to the full rebate one of the big 6 PBMs gets, let's just say if they get 60% off, we get 50%. Well, if I only mark it up 15%, that price that we show on our price list is going to look a whole lot cheaper. And that patient, we already get a lot of Medicare Part D and Medicare Advantage patients who have coinsurance on their specialty generics in particular. They're paying 25% of whatever it is, and it's costing them, maybe just $47, maybe $188 compared to our $34.50 price. And so they're coming to us. And so you do the same thing with brands. And now all of a sudden, all these benefits people, and all the brokers and even the consultants can see the actual prices that we charge. Those big PBMs are fucked. And that's why they're fighting so hard to keep us from participating.
So Christmas is coming up, right? For everybody, right? Q4 is coming up, and a lot of renewals, I think, happen starting in Q4, right? What are the questions that the brokers can be asking themselves to help make sure that their clients are represented, to really get down to the bottom? How can they be critical about the plans that they are kind of offering up, right? Mark and then John. And then, everybody. Actually, we can go around the horn with that one.
Yeah, just ask, is Mark Cuban Cost Plus Drugs part of your network? That's it. Yeah, because then you have a price list to compare to. And if we're the cheapest, you'll use us, just like Caleb does, right? If we're not, you won't. But just having that option, because the big 6 PBMs, and we're even partnered with one of them, won't include us in all their plans networks because they know what'll happen. And, the big PBMs have things like Red Oak, where they're partnered with the big wholesalers, and they keep a lot of margin there. And they require the wholesalers have these things called GCRs, general compliance ratios, where they require pharmacies to buy at least 80, 90% of their generics from them in order to get prices on brands, which in turn means they're paying a premium for generics versus, which is more often than not more than what we charge our patients directly. I mean, the scamishness of it all is just so interconnected. It's horrific. And so if you add costplusdrugs.com to your network, worst case, you're going to get lower co-payments, co-insurance, potentially co-pays, and often, if you're self-insured, lower prices to the company.
Yeah. John, what questions should people be asking, or what should brokers be asking about their plans?
To help their clients, I think the biggest thing is getting the data, and actually shopping the group out. A lot of times, any group with 100 or more, we're trying to get top 20 RX report, monthly claims reports, claims data, all that. And it's just hard to get the data. And, without
Isn't there a law now, John, that says they have to give it to you?
Yeah, 100 or more, they have to share it, but they still don't give you in the right format. Only, sometimes they slow walk it, give you.
What about doing a class action suit between all the brokers?
Yeah, and I think actually my biggest thing I think I could share is actually I think most of the brokers are the problem, right? They're pushing the easy button, and they're doing one of the large carriers. And the large carriers, as you guys know, they control about 80% of the PBM market, and they're just going to and they just shuffle them back and forth. And then the other thing is, it's also, I hate to say it, but a lot of the HR directors are the problem too, because they just want easy. They want that big consulting firm and they're not really looking at I can't tell you how many HR directors I've come across to where you can actually help the company deliver a better end product and a savings, better end product for the member, the whole bit, lower out of pocket, everything, right, and a lower premium, and then they don't want to do it because they have to do work, they have to change.
Well, you let me call him, right? Mark Cuban's on the phone and he wants
Yeah,
to talk to you about your healthcare expenses.
yeah,
That's where I have an edge.
yeah. I just what we find the most luck with is when we come across CEOs and CFOs and HR directors that get the bottom line right. If they can help us get the data, that's when we're able to really deliver the value for the clients. Because again, most of the brokers aren't going to do all the work it takes to do it. So for all the brokers out there, if they really want to help their clients, that's the key, and put in the work. But most don't want to. So especially the bigger the firm is, they just kind of shift you from one of the big ones to the other. That's just the bottom line. So that's where I think it all breaks down. The clients don't know what they don't know, right? So unless there's somebody like us or everybody on this call trying to help them, they just don't know, and then they go the easy route. So that's kind of the bottom line.
Caleb, your thoughts on this? What should they be asking?
Yeah. I mean, I think the average broker should be asking, right, to their carrier partners, do they have access to the data? In the end of the day, the data is king, right? At the end of the day, a self-funded employer in particular, right? They're the insurance company. It's their data. And to whatever degree they want that data, we firmly believe they should be able to have that. And I think that's really what this boils down to, right? And you dive 3 layers deep into can I see my data or what's in the data or what have you, right? And you unpack all of the transparency, right? You unpack how people are making revenue, where the revenue is going, and at the end of the day, you follow the dollars, right? There's a reason that we're able to offer, John's clients flat renewals year over year over year. There's a reason, we believe in a healthcare budget reset, because again, a flat renewal is not necessarily a good thing, right? And that's what I would tell, the average broker, the average client. A flat renewal means that's probably your best ever opportunity to go shop, right? To go find something different because you had a good year. You had a good year despite everything we've talked about and despite all of the forces working against you, from a commercial standpoint, you got a flat. Go see what that flat could get you, right? You finally have a bird in the hand. Go take that as an opportunity to reset because candidly, you might not get that again.
Jim, PB Insider, what do you think? What should we brokers be thinking about in terms of how they can best question, the existing reality?
Well, negotiate for 100% transparency. I mean, when you get your reporting, you need to be able to show that dollar for dollar that went out the door, where it landed, and be able to demonstrate that in any case. Because what happens is, I get some of these reports, people will show me and say, well, we think we've got a really good deal. They're telling us they're saving us all this money, and it's some convoluted 70-page reporting package that doesn't tell you anything. I mean, all it tells you is that, maybe they're get a percentage savings on average wholesale price, which is a made up number anyway. So it's like, what the hell does that matter? But, one of the things that, another thing I guess to make sure of is, get the pricing published and make damn sure that what the pharmacies are being reimbursed, so that if there's any spread pricing going on, because that's where, I mean, J&J and JP Morgan and Wells Fargo got into so much trouble because they had agreed to pay $10,000 a month for teriflunomide that you could get for $29 at Publix Market. I mean, that was in the contract. So that's another reason, John, an issue that some people don't think about in terms of the reluctance on the part of a plan sponsor to find out how bad are we getting ripped off. Well, hell, if you figure it out, and the shareholders might come after you and fire your ass, or the employees may come after you and say, hey, you weren't doing your fiduciary duty for the last 5 years. Well, we were paying 50% more than we should.
And that same concept,
so I think,
John, Jim, tell them about what happens with independent pharmacies or all non-captive pharmacies. When they underpay on brands, there's a lot of times they won't accept the script. So you may have an employee or somebody, a member, that goes to the same pharmacy. They've gone forever for their GLP-1 or their Eliquis, whatever it is, and that pharmacy tells them, nope, we're going to send you to small town farm. We're going to send you to some other pharmacy 2 hours away because there's nothing else close by that will accept this script. And
Right.
so when you approve your contract, if you're the CEO, you don't want to be in a position where you're putting your local independent pharmacists out of business.
Yeah. Well,
And most
Mark,
of these contracts know exactly what they're doing.
yeah, you may not know this, but my organization is actually owned by independent pharmacists, and one of my owners was telling me, small independent pharmacy, he's like, every time, Joe walks in the door, I know I'm going to lose $200 that day because he's filling a script that I'm getting reimbursed below what it cost me to buy the damn thing. And I had an experience just a couple months ago where I called my independent pharmacy that, where I get my prescriptions, and they said, well, this one we can't fill. You're going to have to go elsewhere because we're reimbursed $80 less than what or $80 less than what it costs us. And I was like, holy, here it is
I
coming
sat
home
there
to
in front of
roost.
CEOs and I said, look, you've got retail locations all across the country. And I guarantee you, your brand prescriptions that your members are getting are putting small pharmacies, and even look at Rite Aid, they weren't a small pharmacy. Walgreens had to get sold. They weren't a small pharmacy. But when you talk to those folks, it was the under reimbursement that put them out of business.
That's right.
And so, the contracts that the brokers negotiate, that the employers sign, those deals are the ones that are putting all these pharmacies out of business and creating pharmacy deserts and making those big PBMs that own or control them even bigger and more controlling.
I do want to add in here real quick, because I know we were talking about what are things that brokers should be asking themselves coming into open enrollment. And one thing I think that is overlooked so much is, okay, you built this amazing health plan, you put in the perfect TPA, PBM partner, cost plus, of course, you can't forget that. And how are you educating the employees on these new awesome options, right? Are you just putting them in Employee Navigator and saying, go log in and enroll? Or are you building marketing material to the employees to understand all these new amazing benefits that you just put into a program? Are you having enrollers go on site? There's a lot of missed opportunity there to really highlight to the employees what you've built. And I think a lot of people build great programs and just forget that last but incredibly important step.
That's a great point, Stephen, because when I talk to HR directors or head of benefits, that's their biggest fear. The transition from what was to what will be, and what are the programs and support programs you have to make sure that members feel comfortable that they're not, to Caleb's point earlier, they're not going to lose their care. They can get access that they still need because they don't care about their boss saving another $57 per prescription. They just want to know they can go to their doctor or their kid can go to the doctor and not feel stressed.
Right.
You were talking about, Mark, this cost plus wellness, right?
Huh?
Is that like a sports program too, or is it purely just
No,
not?
we make no money off of it. It's just a communications and transparency program.
Hmm.
You guys have never seen, unless you've negotiated, never seen hospital contracts, right? The provider contracts, they're just not readily available at all. And so we just want to change that. Just like we did our price list, which changed the game, we want to make every contract that we can possibly negotiate anywhere in the country available to everybody.
So Mark, I work with several, not smaller, not newer, but they're less well known, insure tech companies. So if you're ever looking for an introduction to a carrier that's wanting to be innovative in their contracting.
Sure. I mean, you guys got my email. Send me anything. I live for this stuff. To me, this stuff is interesting. I mean, I love learning it. That's why I pay attention. That's why I'm here.
I'm just learning every day.
There's more acronyms than there are in sports analytics. It's insane. you
That's a
know? And so,
great
yeah, there's a
segue.
lot to learn and I'm still learning.
I got a question for you, and I know we've taken up a lot of your time, and we appreciate that. This is a weird question, but I think it's important to ask. How do you come up with the names? Or where you don't come up with the names, do you? Where do these names come from all these drugs?
Wait, the names of the drugs themselves?
Yeah. Where do they
I
come
got no
from?
fucking idea.
It's
You
there,
know?
and poor you. You got to like remember all of them. It's just
Oh, I
gotta be
never
so
remember the
complicated.
drug names. I pick a couple like a Matinib, Eliquis. You know, I'm at that age where like I always talk about Tadalafil, but particularly with my friends, you know, because we've got the joke I always use with my buddies and CEOs if they're that age. I'm like, you can buy a big bag of M&Ms for $9.95 and put them next to your bed, or you
Yeah.
can buy 90 Tadalafil from us. Which do you think is going to bring you more pleasure? And so, you know, and now we've got, even with the rows and the hymns and all that kind of stuff, we think we've got more than 10% of the market because our pricing is so cheap. And for like a Matnib, we probably have more than 25% of the market now and growing.
Wow.
You guys are starting to go into manufacturing too, right? I think you got a place in Dallas
Yeah.
that's doing
Yeah,
manufacturing.
we've got a Dallas manufacturing plant where we do sterile injectables.
Mm.
We're in the process of adding the ability to make biosimilars as we get approved for them. We're adding some other pieces where we'll be able to make oral solids, maybe by the end of next year, so we can scale up. We're doing things where, you know, there's the key starting materials and then APIs that go into the manufacturing of drugs. So we're doing all that as well, but that's going to take time to get put all together.
Do you have to get approvals like state by state or something like that?
Yeah, we've got most of the state approved. Most of it now is just FDA based stuff
Mm-hmm.
where you've got to, you know, for anything you add or package or label, you know, we've got to get it all approved, which is fine. We have no problem with that.
How do you decide which like, or when you guys started? How are you deciding which drugs to use first?
Well, the ones we manufactured were the ones that were in short supply. And so we went to different hospitals and said, okay, which drugs do you have the hardest time getting and at what price? And here's our cost and here's what we can sell them to you for. Are you interested? And the answer was yes. And so that part's growing. Then we have another business where we sell to hospitals and clinics called Cost Plus Marketplace. And as convoluted and messed up as the patient pricing is, it's just as bad with bigger numbers for providers and hospitals. And so if you go to, I think it's cpm.costplusdrugs.com, we sell, you know, sold to Penn Medical and saved them $4 million a year. CHS saved them millions. I mean, I don't even know all the names of the hospitals and the clinics because we just take a 10% typically markup on, you know, what we do in that wholesale business. And because we don't have to keep any inventory, we do it all virtually. We can sell it so inexpensively. Whereas, you know, the typical purchasing agent is just going to all the wholesalers and just paying whatever price that they charge, and they're getting ripped off. And so, you know, we have a guy, Alan Bowe, who's brilliant in all this stuff. And that's another part of our business that's just exploding. And we're saving all these clinics and hospitals a fortune. And eventually we'll get into devices and all that kind of stuff because, you know, a different size hospital will pay dramatically different prices for like a hip implant or a knee implant. I mean, I never knew that it was so distorted even for big hospitals. And so there's a lot of room for us to expand there and do the right thing.
When you think about that expansion, do you guys think about this in like terms of 5 or 10 years, or is it like, you know, as quick as you can?
We want to do it as quick as we can, but the whole goal is to fuck things up, right? So you've got to be, you know, proactive and reactive depending on, you know, what else is happening in the industry and look to see where our weak points are. And, you know, you guys have talked about it. And obviously Caleb's done a great job with Angle that, you know, there's a lot of education that has to take place. That's the hardest part. Mm-hmm. And you guys have been clear. It's not, you know, coming in cheaper. We're cheaper, you know, almost all the time. It's, you know, who are we competing against? What's their overhead scenario? And in this industry, to your point, John, that you were saying earlier with the $130,000, like the overhead is just insane. We've got 70 people in all these different business lines, 70, that's it. You know, we've got AI that drives most of our manufacturing with a lot of smart people managing it and dealing with it in factory. Um, but we just keep on pushing wherever we see an opportunity. And while everybody else is big and doing it the same, slow, methodical way that healthcare has always worked, where, like I said right off the bat, healthcare is really a simple business. But on the financial side of it, because it's $5 trillion, everybody just tries to arbitrage their little piece.
Yeah.
If you can get 1/10 of 1% of a $5 trillion business, you're killing it. And I'm not going to lie, if I was 25 or 35 and starting a company and I built this up, I'd be like, let's sell this shit. But I don't have to do that, right? My joy comes not from my next dollar. It comes from looking at the response of a lot of these carriers and the PBMs they own to us, this little company that started 3 years ago. They're having to come up with programs in response to us, but they can't do it because of all these convoluted relationships they have. Yeah. And so they have to try to work all around it and grab a nickel there, grab a dollar there, as Jim talks about all the time, create new fees, hide them so people can't do it. And John, don't show claims because they know the prices are too high, and just obfuscate all you can. That's opportunity for an entrepreneur. And just like you guys, all you guys really walk in the door and say, I can save you money, right? Because you see those opportunities. Now it's just educational. And that's why I spend so much time doing these things, because I got a platform. I can go on national TV. I can go do interviews. I can tweet or post on wherever. And not everybody's going to listen to me, and I'm going to get a lot of shit, but I'm going to sink in some places.
Right.
And then I'm going to just pass everybody on to you guys and say, you know what? These are the good guys.
Yeah. Do you think that you're going to ever do anything because right now you have a huge megaphone, right? You can tell people about what your guys are doing. You can bring awareness to these issues, right? Do you think it's ever going to come to a place where you're doing, I don't know, promotions at sports events, right? Sponsorships like that, or you probably
doubt it. We've spent total of, for marketing and promotion, $0.
Nice.
Not a penny.
Yeah.
And the reason, because when I first got started with Alex and we hired him, they're like, okay, what are we doing on marketing? What are we doing on promotion?
Yeah.
I'm like, let me just tell you this.
Yeah.
If you save somebody $100, $500, $20 on their monthly medications, they're going into that Facebook group where everybody has that same illness and telling everybody. And then they're going to tell their doctor. And then the doctor who treats everybody with that same illness or whatever it is going to recommend it. And those people are going to tell each other. And as we add more drugs and continually push the price down, because if you go back to cost plus drug and your cost for imatinib was $44 3 months ago, and here you are, your 90-day supply is over, and now it's $34, you're happy as a pig in mud, and you're telling everybody. And so again, as long as we retain that trust by being transparent and staying to, as close as we can to our 15% margins, we shouldn't have to. And as long as we keep on finding these angles, and I keep on learning from guys like you and all of our folks, we'll keep on, finding ways to save people money. And as long as we do that, we'll be fine. Because like I said, our overhead is not all that much.
Mm-hmm. Well, if you ever want to, well, actually, let me ask you this. What do you think of pickleball? You ever played pickleball?
I've played pickleball. I'm not a pickleball or padel guy. My wife plays tennis 9 hours a day, so I have to be more of a tennis guy.
Oh, we had a pickleball event for brokers. So if you want to get in front of brokers, we're happy to have you at our pickleball events. They are CE
they would kick my
also.
ass.
It's a lot of fun. Guys, any other questions you guys might have for Mark, throw them at him. But we've taken up a good amount of time, and want to make sure that we respect that. So let me know if you have any more questions. But I think we can close. Actually, have one more question for across the room, right? I want to ask everybody this. This is a book. Obviously, your book came out a long time ago, Mark. So that was one of my favorite business books. But I'm curious, from your perspective, what's one of the best business books that you've recommended to people?
Other than How to Win at the Sport of Business by Mark Cuban, which is only 80 pages long. I kept it really, really short. So it's really easy to read. How to Win at the Sport of Business. The book I like the most for entrepreneurs is a book by a guy named Eric Ries, Ries, The Lean Startup. And it basically says, you know, focus on being profitable first. And here's kind of the mindset to get there, because particularly for startups in this day and age, it's all about revenues and how big can you get and how big can you look, as opposed to actually making money. And as interest rates go up, as we found out, you know, there's a lot less money available for, you know, investment, and a whole lot of companies are going out of business. That's part one. And part two, read everything you can about AI. There's going to be two types of companies in this country, in this world: those who are great at AI and everybody else. You know, that's why Caleb does what he does, because, you know, there's the ability to use it in ways that people don't even understand how powerful it is. And the crazy part is AI, not only is it just beginning, AI is stupid. It can't think. All it can do is suggest what comes next based off of what it's been trained on. And so you still need to be smart. You still need to know what works. You still need to be able to add value, you know, like in Caleb's, integrate, to know where to apply it and how to apply it. But still, you want to try to figure it out. I mean, if I was a broker, I would be, you know, feeding in all the data I have, and I'd say, you know what, what's the best way to write a proposal for this client given A, B, C, D, E, F? And then based off of all the clients that you've fed, what am I missing that I should be included, or what, you know, tell me about all the brokerage contracts you've read or industry information you've read that can educate me on new things I'm not doing. I have conversations, like literally, I was driving down the road the other day and I said it I use ChatGPT, Gemini, Perplexity, Claude, all of them. And I turned one of them on and I was just having a conversation, and it was just answering questions about Medicaid for the state of Pennsylvania.
And it just tells
it was
you
telling me
everything.
about the you know, the pharmacy drug list and all that shit, right? That I didn't know, but it had read all of it. That it had been trained on all of it, and it didn't have to think. It just, you know how we all have that one friend that remembers everything, and you go back to them and say, you know, what did we do this day, or what? That's what AI is right now. It knows everything that it's been fed and remembers it all, and it's not always going to be perfect, but that's your job to know where it's right and where it's wrong. That's your value add. But boy, it'll come up with suggestions and ideas that I had not thought of. It educated me on things, so I didn't have to do 90 Google searches and go through 150 blue links.
Yeah.
It's just incredibly powerful. So, you know, my book, The Lean Startup, and just dig into AI.
Yeah.
Ask it the weirdest question about being a broker you can possibly think of. I guarantee you, you'll be shocked at the answer.
Jim Lodge, what's your favorite business book?
Well, Mark stole my thunder because, of course, you know, it's How to Win at the Sport of Business. But actually, instead of a book, if someone, what I recommend to my brokers is and or clients is, hey, if you really want to understand the state of the industry today, there was an article that came out about a year ago in the New York Times called "The Opaque Industry Secretly Inflating Pricing for Prescription Drugs." And that article, it's about a 20-minute read, but it does the best job of summarizing all of the different issues that we're talking about with respect to PBM. And so I always recommend that to prospects, clients, brokers, whomever.
Beautiful. Caleb, what about you?
No question. Industry specific. There's a few books by Al Lewis about "Don't Believe the Numbers" and why wellness is BS, and others there, which I think again teaches you to challenge, right, so many of the numbers that are often presented in this space. More generally speaking, in the business world, The Long Tail by Chris Anderson's always been a good read. Really talking about democratizing distribution. And again, in this space, right, when we're all accessing healthcare benefits, it's personal. It is the longest tail, right? And that each and every person is unique and that their experiences are unique. And truly, one size does not fit all. I think, again, being able to build product and distribution and stories around that become incredibly impactful and important in this space.
Is he the guy that started the TED conferences? Is that Chris Anderson? No, different
Might
guy.
be.
Yeah, that's the guy who started Wired, Chris Anderson. I
Yeah,
don't
yeah,
know if
yeah.
that's the same guy.
Same guy.
Different Chris Anderson.
Oh,
Different
different
Chris
guy.
Anderson.
Okay, that's what I was thinking, right? John, what about you? Favorite business book?
So industry specific, one of the other TPAs I work with, lady that runs it, her name's Madeline Smith. I don't remember the name of it's a pretty like brash name. I can get it to you to maybe add to this later, but
Yeah.
she's it's basically about cutting all the excess and bullshit out of healthcare, and she basically the name of the book is somewhere along that lines. So
Okay. What about
real cool.
non-industry specific?
I actually Anthony Robbins Unlimited Power. I think it's could help anybody. I really do. Help you formulate anything you want to do in life, and not just business, but overall.
Yeah.
I recommend it to any of my salespeople to read it. Just a good foundation for everything. So,
Steven.
I know I talked about this earlier with you, and it's not really, I wouldn't say it's my favorite book, but it's one of the books I started reading when I first started getting into entrepreneurship, and it was Rich Dad, Poor Dad. And it really got me involved in learning about, like, I don't invest in real estate, but anyone who knows me, I'm big in the stock market and into crypto as well. And it just really got me
To the moon, baby, to the moon.
to the moon, yeah, to the moon. Hey, Ethereum's up today a lot.
Big time, I know.
Big time. So it just got me looking at finances more strictly. Like I was telling you earlier, if I look at something that I want to buy that's a giant waste of money, I don't look at what it's worth today, but what I could have invested and what that'd be worth in 20, 30 years. And so that's really got me in a place where I was able to start a business and be very economical with my money. So that was, to me, the first book that really got me considering, the investing and being smart with my money. So.
Yeah. I would say Traction. Traction is a great book. That and also a book called Work the System by Sam Carpenter. It's really good because it makes you realize everything's just a system, right? And if you can simplify it well enough, then you can really understand it better, and then you can manipulate it however you like to. And I think that's how you guys have built your businesses too. Well, wonderful. We appreciate you guys jumping on.